So value-based payment programs have traditionally focused very heavily on reducing acute care use. So in the oncology care model, the program cites that we should be providing increased access to care, 24/7 coverage, so that patients can have their symptoms managed before presenting to the ED. The quality metrics have been focused on hospitalizations, earlier transitions to hospice, and reducing emergency department visits. And so in our goal of participating in this program, we built a tremendous amount of infrastructure to reduce acute care use. So at Yale, we opened an oncology urgent care center that's open 16 hours a day, 7 days a week. We started a care management program with very senior nurses who watch patients across their interactions with the health system, both in the hospital and out of the hospital, and try to provide continuity to address their care needs before they escalate to the point of a hospitalization. We also implemented clinical pathways to standardize care and our increased access to palliative care in the outpatient setting, or ambulatory palliative care. And actually at Yale, we've been tremendously successful. So we've really reduced hospitalizations and ED and post-acute care. We've earned more than $6 million in performance-based payments and all the quality points we could up until this point. And we've kept the cost of each of those aspects of utilization stable. So you would think in doing all that, we wouldn't actually see a rise in the total cost of cancer care. But in fact, we have seen a rise in total cost of care. Now, according to CMS, we've actually saved money because our care has not escalated as quickly as everybody else's, or everyone else's, but you actually can really begin to understand what the components of spend are. So what we've seen actually is that the amount that is spent on drugs has increased in all of these 6-month episodes for our patients. And in the baseline period before we participated in this program, the cost of care for drugs was about 50% of everything spent on cancer care. And now we're seeing in the performance periods that percent is closer to 60%. And that's at Yale, where we've been successful in controlling costs. And for the 2/3 of practices that have not been successful in saving money, it looks like drugs are about 70% of total cost of care. One of the limitations of this model is that for a patient to be part of the program, they have to be on systemic therapy, so the population is limited to patients who are on drugs, and so that may somewhat overestimate the contribution of pharmaceuticals to total cost of care. But essentially, what our research shows and what our data, from thousands of claims and episodes in the oncology care model, is that even when a practice or an academic center or a hospital system is successful in reducing utilization and controlling cost of care, pharmaceuticals are still accounting for an increasing proportion of total cost of care. And so the idea that we can control costs by focusing on oncologists' utilization of acute care is not going to solve the bigger problem of rising costs in cancer care. And future value-based programs, if they're going to be successful, have to tackle this issue of increasing pharmaceutical pricing.